We're moving on now to something that I know is an issue for many of you, and if you have the tiny kids, well then you've got those things and you've got more to look forward to, and there's great ways to navigate being a teenager. I know sometimes it gets very daunting, but there are ways to make it easier and better, and that's why we brought Dr. Elizabeth Byers here to tell us about navigating and making your way through puberty periods and the complex teenage years. Thanks so much for joining us.
Hi all. Well, I have to tell you, I walked in during a genetic talk and I was definitely like, what the heck am I doing here? So Carrie, and that last question, thank you for that, because I think it bridged exactly one of my messages, and that is that, are my slides coming? That is that adolescence is something to be looked forward to. I am so sick of people giving teenagers a bad name. I do a lot of advocacy for teens. They are incredible. It is an incredible time of growth and change. And the fact that your kids are going through the physical changes of puberty actually means that they're getting the nutrition and love that they need. Because if they don't go through those changes, it's often, I mean, it can be okay, like we can figure it out, but I just wanna, I would love everyone to think of it more as a good thing. I also, just to do a transition, I can't tell you how many people bring their children to me and blame everything on the hormones of puberty. This is just false. I know there are people out there making lots of money on selling reproductive hormones, that is testosterone, estrogen, and progesterone, as somehow, these panaceas for everything or the cause of everything bad. It is just not true. And so please recognize that when behaviors start to get out of control at any point in your child's life, it's not just about their testosterone, their estrogen, and their progesterone. And please reach out and get some good ABA. So I don't know how to operate this. Is this it? Just press it. There we go. Okay, so my plan for today, and I am completely open to changing this. Now, if you have children who have testes and not ovaries, I would say this talk is still applicable because you probably have people with ovaries in your life, and there's a lot of, this is just a lot of general information. But I do have like 2 slides that will be applicable to people without ovaries. So just to talk about, just kind of like generally about adolescence, to talk about periods, what they are, guess what? A lot of us didn't get a lot of education about what periods actually are, and then to talk about just some really concrete treatments and therapies. And again, there's a lot of people in this room with ovaries, and I can't tell you how many times I offer menstrual suppression to a kid, and mom is like, what? Get me, get me this too, and improves everyone's lives. So that's okay. My husband was diagnosed with ADHD after my daughter was. I'm sure, there's a lot of that. Okay. So again, I am not a psychologist, I'm a gynecologist, but again, just to remember that adolescence, this is an amazing thing. Really the stretch of adolescence, for in terms of brain changes, people with ovaries, not done growing, changing until at least 25. People with testes more like 30, and all of you who are, I'm 50, I think back, like at 26, was I grown up? No freaking way. Maybe you were, but I was not. So really like how your brain changes. And one of the key messages is that changes are not synchronous. So this is another big myth, that kids who maybe haven't started puberty are somehow like the changes going on in the brain and wanting to break away from you and be rebellious and not use you only as, the authority, that can happen really at any time as kids start to get older. It's not necessarily because they've started the physical changes of puberty, and of course the other way around. There's also so much back and forth, and I think you all know that. In some ways you're all so much more in tune with your children than a lot of parents are, but just knowing that back and forth, 3 steps, whatever, a couple steps forward, a couple steps back. I think I've said everything else on here pretty much. This is old data, but I remember like it being big news that the brain is still growing. So the deal is the brain is 90% of its adult size at age 6. And so, just like in lots of things in medicine that we had wrong, I mean, where do I start? This is yet another one where like somehow the brain is done because its size is done growing. But all the connections that happen over adolescence and really happen over your whole life, but especially during adolescence, it is such an important time to invest in developmental strategies and therapies and to get yourself the help you need. That's the other thing. It's a time where if you don't have the support you need, you're gonna break. And that's true, I think, for a lot of families. You can no longer scoop kids up. You can no longer, it just becomes a time where, get the help you need. Okay, this is another message. Sex education at home. And, I've kind of stopped doing them, but where people are like, can you come talk to our parents about how you talk to your kids about sex? And you all, again, are so intimately involved, most likely, with your children and their bodies, really, for many years. And how this works is just from day one, and it's never too late to start doing this, really being intentional about, body boundaries for yourself, what's appropriate for yourself, like how people can interact with you, the privacy you need. And then when you are, maybe helping someone with hygiene, just explaining why you're doing it. I think you will see this more and more with your pediatricians when they're examining your kids, saying to them, hey, listen, the reason I'm, looking here is because your parent is here and I have permission to do that. But just really routinely doing that with your kids, I know that can kind of be like, what? But ideally that would be a good thing to do. They hear you. I mean, just like that video. I mean, there's so much going on there. The same way with how you treat their body, and if you ask permission, even though, of course, it's going to be more like assent, or sometimes you're not going to have assent, and you're going to have to say, I really do have to wipe you now, I'm so sorry. But, at least communicating while you're doing it. These are just a couple books. Books are kind of becoming more and more obsolete, but if you have someone with ovaries who's gonna have periods, all of the American Girl books, they have nothing to do with the American Girl dolls. They're really nice, and they have nice little cartoons and showing nothing about sex, just about bodies. That one's very nice. And then Roby Harris books are excellent. She has one for ages 3 and up. It's called It's Not the Stork. One for 7 and up, and then this is one for 10 and up, and that's kind of the highest level. And it just goes through everything, like people with penises, these are different body shapes. I mean, it really just goes through everything in a very friendly, at-home way. And again, I really would encourage you to talk about these topics. All of us are sexual beings, even your children. And it's really important that you include this aspect of their life. Again, what happens in private, but just not talk about it. I feel like anyone left here, again, I'm always talking to the choir. So everyone who isn't here and at the dinner tonight, will you please tell them that, listen, I noticed you weren't at that talk, and is that because, you somehow think you are getting out of this for some reason? Because you're really not. We're gonna talk about menstrual suppression, and we're gonna talk a little bit about just birth control. Again, I mean, that is something that, again, all of you are here. I think you all know that abuse and sexual activity is actually something that could happen to your child, but really just knowing about it is incredibly protective. So this is a website. I have not found amazing resources around sexuality for people with disabilities. So if anyone knows of anything, there's more probably for Down syndrome. There is stuff for autism. But this is a nice site that has lots of resources on it. And I like it. You know, I haven't found the perfect one. That's actually on my to-do list, is just to update kind of a guide for people who are going to have periods with developmental disabilities. Because there are some, but they're really old. There's one that has like belts for pads. You know, like, ooh, what were those? Okay. So let's just talk about what puberty is, because I feel like there's a lot of confusion, and just so you can understand. So puberty starts in the brain, and the hypothalamus sends signals to the pituitary. The pituitary then sends signals to the gonads, and the gonads there are intersex people, but in general, ovaries, which will go on to make estrogen, and testes, which will go on to make testosterone. And those hormones then lead to all the secondary sex characteristics. This is a slide that I am not authorized to really talk about, because I really don't see people with testes, especially at young ages. But for people with testes, the onset of puberty tends to be later than with people with ovaries. And the first physical finding you will see is growth of the scrotum and testes. So that is because the testes start to make testosterone and things actually grow. Testosterone also may cause a change in the voice, lengthening of the penis. Again, these are things that if you're helping your kid with hygiene, you're gonna see. If you're not, you may not see. And the other thing to know, and this is true for both, for all genders, is body hair, pubic hair, armpit hair, acne, and body odor, that's actually run by adrenal hormones, and the adrenal glands sit on top of the kidneys. So actually there's a process called adrenarche, which is actually independent from puberty. So with all genders, sometimes adrenarche, pubic hair, body odor comes before the gonad turns on, and sometimes it comes after. So but it's not uncommon for kids to develop like pubic hair, but puberty not to start. It's a good thing to talk to your doctor about, but just so you know, it doesn't necessarily mean that gonads are turning on. Okay, this is my population. So I see lots of families when their children start to develop breast buds. So the way you know that the ovaries are turning on is that estrogen causes the breast to grow. And the breast bud, you know, the chest is flat, then the nipple pops out. It can be painful, it can be one side, it can be both sides. And then over time, estrogen causes the breast to grow more. It also causes the uterus and the uterine lining to thicken. And that is what gives you that first period. It takes 2 years from breast bud to get your first period. Now, lots of your children don't read the textbook, okay? So I will see sometimes some very rapid, you know, but usually when you see that breast bud, you then have about 2 years to the first period. And we commonly see people, we don't start menstrual suppression before the first period. However, we commonly see people talk about the plan, talk about the options based on your kiddo's history, and we can get that plan in place. And it can be really helpful for, you know, whatever concerns that you have. Delay, if no breast bud by 13 or 14, now there may be an easy explanation for that, but I would say you would expect to see that. And then if your kid does have breasts but hasn't gotten a period and it's been 3 years or more, that would also be a reason to come see a gynecologist. Oh, the other thing, a lot of people have never heard of adolescent gynecologists. We're a relatively new specialty. Most children's hospitals have us. They don't value us because we're not pediatricians necessarily. We are gynecologists who then do training to work at Children's Hospital, but our numbers are growing, and I encourage you, if you're at a Children's Hospital, to seek us out. I love adult gynecologists. I was one for 25 years, but the management of teens really is different than adults. So just to be aware of that. And one of my missions is actually, a day a week, I teach pediatricians about adolescent gynecology and sexual health. So actually, I think almost everything in this talk, your pediatrician can help you with. Like, great if you have the opportunity to go to a children's hospital and see a gynecologist, but often you don't have to. We can support your pediatrician to give you all of these options as well. Okay, so menstrual bleeding. One of the really important things to understand is I think most of us, well, if we did learn about periods, kind of got taught that every time a person bleeds, it's because you make an egg, you don't get pregnant, and you have a period. Do you remember that is what you were told? Well, that's not true. So the lining of the uterus, what we talked about, that gets thick in response to estrogen. Especially during the first year of periods, at least half of periods, half of the time of those cycles, aren't because someone ovulated. It's just because the lining has gotten thick enough and then they bleed. And so things can be pretty crazy for the first couple years. It takes 6 to 8 years for most people to become regularly ovulatory. And that said, if your kid starts their period and they're bleeding longer than 7 days in a row, you really, that's something to definitely put on your radar, because people become iron deficient and then anemic quite quickly. And that's one of the education pieces for pediatricians, or doctors in general. They know that things can be weird in the beginning, and they often don't they just say, oh, that's your first year, it's okay, you just bled for 3 weeks. No. If you're bleeding longer than a week, let's figure it out. The other thing is periods should be coming about every 3 weeks to every 3 months. That becomes every 21 to 45 days. But if your kiddos or you are far outside of that, not on hormonal therapy. We'll talk. On hormonal therapy, any pattern goes, but just to be aware. Okay. So why do I see families? Lots and lots of reasons. We just looked at a cohort of 100 kids with developmental disabilities, and we surveyed their caregivers. Why are they coming to see us? Hygiene concerns by far are the most common, but most people, everyone also has multiple concerns. So yes, there's hygiene and okay, now I have another, thing to deal with, menstrual blood and fluid. But often concerns about seizures, just irritability. If mom has really painful periods, they're really worried that their kid's gonna have painful periods, and the communication. So just a myriad of reasons. Having contraception on board to prevent pregnancy, God forbid something should happen. Just lots and lots of reasons. And this is my message to you. You want to see a provider who doesn't need a reason. So the only reason people have periods is so they can have babies. The period serves no other benefit to you that I can find. I mean, it's good. It means that you're making estrogen, you're making progesterone. It means that you're healthy. However, the actual functions of the period, the ovulation, the lining, all of that relates to the ability to have children. So if you're not trying to have a child and your periods are bumming you out, it is perfectly safe and wonderful to do suppression. And often people are like, well, that's not natural. And I have to remind them what is natural. And less than 100 years ago, people had 8 to 10 children, and they didn't have periods, because if you've had a bunch of kids in a row, you are pregnant or breastfeeding, and then you're pregnant or breastfeeding. So, again, and looking even farther back than that, hunter-gatherer women definitely had very few periods, because in times of famine or stress, often you lose your period. So again, just that's a little bit of a stretch, but I just want you to know, don't tell me it's not natural, because I will tell you what is natural. Okay. So how do these medications actually work? The evidence is not strong, big surprise, with a population of physical and developmental disabilities. However, we know how they work in some ways. And so at the level of the brain, there's all these negative feedback loops in the body, right? You make thyroid hormone and TSH and all these negative feedback loops. So the ovary tells the brain tells the ovary to ovulate every month, and the ovary makes progesterone. Well, it turns out if you give low dose progestin, then the brain does not tell the ovary to ovulate. So the presence of low dose progestin will stop ovulation. It also stops, you see, FSH, LH, it also stops this estrogen and progesterone, and you have a flattening of estrogen and progesterone throughout the month, okay? The other way it works is progestin it turns out, so estrogen makes the lining thick. Progesterone, when you ovulate, matures the lining, and then the hormones go down and you bleed. But progestin in low doses causes atrophy or thinning of the lining of the uterus, and that is why it is safe not to have periods on hormonal therapy. It continues to keep the lining thin. So those are your two kind of mechanisms. This is a handout that I use in the office when we're very person-centered. So that's how it should be too. Like, you know, there isn't a best option. I love, like, you know, talking about goals. Like, what are your goals? Is your goal never to see a drop of blood? Is your goal to maybe see if we get rid of these hormonal ups and downs, we can have better seizure control? Like, make sure, you know, when you're doing this, we know your goals. And then what's best for you? Like, if you cannot manage one more medicine, you know, maybe we shouldn't do something. Maybe we should do some kind of long-acting option. If medications are easy for you, great. You know, can your kid swallow a pill? I mean, there's lots of considerations. All of these options contain progestin. Progestin is safe for everyone. Progestin does not affect blood clotting. So you know, the birth control pill, the patch and the ring, they have estrogen and progestin, and estrogen is contraindicated in some individuals who have independent risk factors for blood clot and stroke. Okay, so there might be, you know, you may have heard like, oh, I can't take birth control. That would be true for an estrogen-containing birth control. There is a method that is safe for everyone, okay? And the reason to consider the pill patch ring with the estrogen is because that helps with acne. So just so you know, if your kid is struggling with acne, acne is not fun for anyone. Lots of kids pick at it. You don't like the way it looks. They don't like it. And so that may be a reason that you go to estrogen. If you have no desire for that, then maybe you do stick with a progestin-only method. Okay. So my plan was just to go through these methods and get you guys to dinner early. Does that sound good? Okay. And again, you know, this is just general information. So like, good to know. So there are lots of different kinds of IUDs. Stands for intrauterine device. Levonorgestrel is a type of progestin. The Mirena has been on the market now for over 20 years. There's a generic called the Liletta. There are other hormonal IUDs, but these have the best chance at stopping periods, which is usually everyone's goal. We routinely place these under anesthesia for people that don't want to have it done in the office, and that's just not for developmental delay. That could be because of a history of trauma or whatever. We often combo with other cases, you know, sedated MRI or dental work, and it's not, you know, it's not 100% no periods ever, but 80% of people will not have periods at a year. Periods will be lighter. It works locally, so about half the time ovulation is suppressed, but half the time people are still ovulating. Despite that, we see an improvement in seizures. I mean, it's not great data, but you would think that if it wasn't suppressing ovulation, you wouldn't get any benefit for seizures, but we do. We don't really understand. It's possible just that that cascade of events that happens with periods around inflammation and pain could be a trigger for seizures. So the Mirena was approved for 5 years. The approval got changed to 7 years, and we now have evidence that it works for 8. So even though it's a, you know, it's a procedure, blah, 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 it's 8 years. So that's really, really nice. So this is one of our most popular methods. And again, the bias, the patients who are coming to see us probably are already interested in this. And about half of our patients with developmental delay opt for an IUD. This is an amazing medication that I can tell you as a general OBGYN, I didn't know that much about. It is actually a medicine approved to treat endometriosis, and endometriosis is where the lining of the uterus gets outside the uterus and causes scarring and pain. Well, this is a progesterone-only medication which causes the lining to shrink. So, if in the uterus, the lining shrinks. And it is safe for almost everyone. It crushes very well if people have G-tubes, and you can give it continuously. There are some hiccups in the beginning, but most everyone can be suppressed if it is taken regularly. So it's a really nice option. It is not an approved contraception. It just hasn't been studied in that way, but just so you're aware. We've already talked about the pill patch ring. If people are like, well, how do you not have your period on the pill? So the pill was designed 60 years ago in an era where providers didn't explain how anything worked, and probably there was a belief that women wanted to have periods. But when you're on the pill, you're on medication for 3 weeks, and then the placebo week you're not on, so you have a withdrawal bleed. Well, that placebo week is completely medically unnecessary. So you can take continuous pills that's totally safe. Most people will have breakthrough bleeding. You do a 4-day break and you start again. You can also do that with a patch or the ring. So this is another option. Depo-Provera, when I started at Children's 10 years ago, Depo use was incredibly common among kids with special needs because there was evidence that it really helped with seizures. Progesterone lowers the seizure threshold in studies. In practice, all methods help with seizures, but Depo is an injection you get every 3 months. The reason that we've really turned away for it, we have other long-acting options that weren't available. So the IUD and implant are relatively new. Depo's been around from the 80s. But the other concern is that Depo slightly decreases the level of estrogen in the body, not to any crazy level, but there is concern about lower bone density. And your kiddos may have other risk factors for low bone density related to not being ambulatory, not being weight bearing, or being on other seizure medicines. So I'm not someone to say, I'll never give Depo to anyone, but it is a consideration, and we really are kind of steering away for long-term use. If Depo, though, is the answer, we do have lots of families where they swear by Depo as it helping with their seizures and mood. There is a home option a lot of families don't know about. You do not have to drag your kid in for injections every 3 months. There's a form that can be ordered, and you can give it, or they can give it themselves in some cases. Okay. I think this is my last option. This is the Nexplanon, that's the brand name. It's the implant that goes under the arm. It is the best contraceptive method we have ever seen. We don't see failures with the Nexplanon as long as you get it in and you're not pregnant or in that luteal phase. It's super easy to place, 30 seconds. It definitely suppresses ovulation, so a lot of our neurologists will send patients to me, they're like, get her an implant. The problem is they haven't mentioned the bleeding profile. So if I put 4 implants in, 1 out of 4 people will be amenorrheic, that means no bleeding. The other 3 out of 4 will have unpredictable bleeding. So if that's not a problem for you, a lot of families are like, well, she wears pull-ups all the time, not a big deal for us. Great. This is a great option. But if menstrual suppression is your goal, you might get it, 1 out of 4, but we have no way to predict. So just to be aware of that. And this is 3 years. It's very easy to put in and out. We do need some cooperation, but often we can get this done in the office if it's a method that you and you're good with. Side effects. I love the discussion about side effects. My approach to side effects is listen. This stuff is really well tolerated, okay? Most of the biggest concerns about side effects are weight gain and mood. And the reality is, if you look at 100 people on hormonal therapy, 100 people, 50 on hormonal therapy, 50 not on hormonal therapy, in equal amounts are they struggling with mood and weight gain, okay? These are concerns of life and aging. There are some methods like Depo-Provera that do promote appetite. Again, that's sometimes less of a concern if you're providing nutrition for your kids. But there is no real mechanism for just adding fat, so just to be aware of that with hormonal therapy. And the pill, patch, and ring are not associated with weight gain at all. That has been studied very well. Again, people gain weight on it, but if, so the way I deal with the most common side effect is breakthrough bleeding, irregular bleeding. I gave you this method and I told you it's gonna take away your child's periods, and now they're bleeding all the time. You know, like, oops. So reach out to your doctor, figure out what to do. Do we need a different treatment? So bleeding by far is the most common side effect. The other one is there are these fancy word idiosyncratic, which means, you know, you have a side effect that isn't reported in the literature, but, you know, you just want to know. The luxury we have, especially with these short-acting methods, is I say to families, well, if we have the luxury of stopping it for 2 weeks, let's do that. Or stopping it for a week or whatever, like, let's really see. And then once things settle down again, do we want to try something different, or do we want to try it again and see if it caused that side effect again? For example, moods, rebelliousness. I mean, some of the stuff that is like, okay, like, it could be related to this, but it also could not be. It could be related to something going on at school. And so that's the approach I use. Obviously, with the long-acting methods, that's not so easy to do. So if side effects are something that you really are concerned about, and I completely respect that, I encourage families to go with an option that is out of their system in 24 hours. And the norethindrone acetate and the birth control pill and the patch are. So you can start them, and if you're like, whoa, 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 you can stop them. Your child will probably have a period, but nothing else is gonna happen, okay? Treatments to avoid. So we do, you know, of course, if you hear about something that sounds amazing, you want it for your kid. But we don't give suppression until someone's had their first period. Now, this can be a day of bleeding, okay? There's no reason to wait until they have like regular cycles or blah, blah, blah. That's not necessary. But we do want to make sure that their hypopituitary ovary uterus axis is intact, and you know that they have bleeding. We make a plan, and then patients, I have a great nurse, so I tell them, listen, call Ashley and she will prescribe it that day, and you can get started on day 3 of the period. I also tell families, their period isn't gonna be like yours. You know, like, you're often worried that they're gonna have this horrendous bleeding. The first period can be bad, but most of the time it's really just sloughing of the lining, and it's not that big of a deal. You may even be like, is this really their period? And it takes a couple days where you're like, okay, this is definitely a period. Endometrial ablation, super cool procedure where the lining of the uterus is burned or frozen. It's not recommended for people under 40 because the lining grows back. It's also not birth control, so you do not want to have an endometrial ablation if you're not having your tubes tied as well. So it sounds like a great option. It is for the right candidates, but an IUD is equally effective and is also a procedure. So again, I would recommend an IUD, Mirena or Liletta IUD over an ablation if you're younger than 40. Tubal ligation is obviously a sterilization procedure. We have a terrible history in our country and around the world around sterilizing people who have various disabilities or of various backgrounds. That is a history that hopefully your gynecologist would know about and be very aware of that. And tubal ligation also doesn't accomplish really anything except sterilization, and people sometimes don't know that. They think if they get their tubes tied, their periods are gonna stop, and that's just not the case. So I would just say, you know, we don't really view a role for tubal ligation for pregnancy prevention. We have other ways to do that. And then hysterectomy, removal of the uterus. There, again, ethically, there is no role for that. We can accomplish pregnancy prevention and menstrual suppression with our therapies. There are some cases where, you know, we're unable, but that is usually as kids become young adults. If there are gynecologic reasons like fibroids or endometriosis, if those develop, absolutely, you know, hysterectomy can be considered, but that we don't see that usually in people under the age of 25. So anyway. This is our website, CUPAG, so CUPAG, Pediatric Adolescent Gynecology. We have lots of resources there. And the resources are really focused on people using hormonal therapy to help with medical problems as opposed to birth control. So I do think it's a good website, like, to, if you want to show your kid or show your spouse or show a friend, they won't get blown off with like birth control. These methods are all birth control except for norethindrone acetate, but they're only birth control if you're having sex. Just like, I think you all are very savvy to this, that most things we do on children aren't approved by the FDA. And then how many medications do we use not for the reason they're approved for, right? So we use seizure medicines for mood, and we use antidepressants for pain. This is so common. So again, most of these medications are FDA approved as a birth control, but we're using them for hormonal therapy and menstrual suppression. And if we code it as birth control, that's so it gets covered by your insurance at no cost. So the Affordable Care Act mandates that birth control is covered at no cost to the patient. However, that is something that you should all be aware of, and it is birth control, and this is where I think you should advocate that your provider codes it as such, because it is protecting your child from an unplanned pregnancy. These are resources you can bring to your providers if you feel like they need to get up to speed. So the American College of OBGYNs is like, they lay the law on what we should be doing, and they have excellent, and they have for 15 to 20 years, have excellent committee opinions on how to manage periods and the benefits of menstrual management for patients and families that want it. Of course, there's nothing that bums me out more when a patient comes to see me and a family who are like, we don't know why we're here. She has periods and they're fine. For goodness sakes, if you and your family, like, it's no issue, great, God bless you. So don't feel pressured to stop periods, but if it does cause a strain, please know these are well established. And really, any OBGYN in the community should be aware of these guidelines. And if it makes sense for like an IUD placement in your community, I would really encourage you, if you have an OBGYN that you can talk to, they would be able to perform this in the hospital, in your hospital locally. And then this is a YouTube video. We do little provider education YouTube videos. The talk I just gave you is basically this talk. So if you want someone else to see it, you can send them to YouTube. This is my team at Children's. I have a great team, and that's all I have for you.
It was a great talk, Dr.
Oh, thank you.
We've just made it to 18, and I was just nodding through all of that because it really, if your kids are little, it works out well, and there's lots and lots of things. And we have a great children's hospital in Melbourne, and people who are very similar, so it was wonderful.
Yes.
Anybody questions? All right, thank you so much, Dr. Byers. We appreciate it.